Hi everyone, this is Neel Raithatha, consultant, audiologist and director of earwax. Thank you for joining me in this latest video using the iClearScope endoscope. We have here a patient who attends approximately every 6 to 9 months and they experience an accumulation of dead skin, keratin, in their right ear. And there's several reasons for that, which I'll explain during the course of the video. Now, I've started off using the right angled ear hook to see if I could prise this out. I previously have used forceps to remove this, or at least partly remove this, but I think on the last appointment, the one prior to that, when we used the forceps, it did get all this crusted skin out, but it did blister the ear canal somewhat, and the patient did experience some discomfort. So I'm just trying to stay away from the forceps if possible, just for that reason. Now, it doesn't mean it's going to happen again, but if I can remove it using other tools and suction even, that would be kind of more of a surer way of not causing any blistering. So it's really dry though, and I don't want to use any drops in this patient's ear, and that's because they've got a very deep attic retraction. So the attic is the top part of the eardrum, and they've also got a very deep retraction in what we call the posterior superior quadrant of the eardrum, and you will see that. Now, this patient's been assessed by ENT several times in the past, and there's no surgery that can be done for this patient, and it's not, although they have got a very deep retraction and they've also got some opaqueness, so some scar tissue of the eardrum, the hearing's relatively okay in this ear. And they previously used to suffer from a lot of ear infections, and what's been advised by ENT is just to have this ear clean on a regular basis. And that's because when you've got dead skin accumulation like this, which doesn't naturally fully migrate, it can get a bit damp, moist in the ear. It can also release some enzymes. Bacteria can feed off it and also release some enzymes, but it can start causing ulcerations of the skin and then leading to an infection. So I'm just using so far, I'm alternating between the ear hook and the keratin. So you can see it's a bit moist and damp at the bottom of the ear canal. Now, once after removal of this, everything, the ear canal is pretty healthy, and we did remove a lot of dead skin off the ear canal. So if you enjoy skin peels, do stay tuned, because there's a surprising amount of dead skin that we peeled away. So this skin is a bit more moist. It's a fresher layer of skin that's just recently died and shed. And so just scoop some of that away. And you can just see some of the eardrum in the distance. Now, whenever you see a bit of discharge like this, you can sometimes think there's an active infection. So, I mean, there is some bacterial involvement here. This, as I said, this patient does suffer from this issue, but the treatment is just regular cleaning, because this patient's had topical antibiotics for many, many years, and it's not really helped. They may have even possibly become immune to the antibiotics, but as long as we clean the ear and this patient keeps the ear dry with no water, the ear seems okay. Now, the reason why this patient's skin is not naturally migrating is because of this retraction pocket. I commonly find in patients who have got a retraction of the eardrum, and the retraction occurs when there's typically negative middle ear pressure behind the eardrum. And when we say negative middle ear pressure, we mean there's less air pressure behind the eardrum when compared to the atmospheric air pressure, i.e. the air pressure in the ear canal. So when you've got this imbalance of air pressure and it's less air pressure behind the eardrum typically gets sucked in, it buckles inwards, and it normally gets buckled inwards in the attic region, so the top part of the eardrum, also known as the pars flaccida, where the eardrum is more elastic. It's not as tense as the rest of the eardrum, therefore it's more susceptible of being sucked in. And also the posterior superior quadrant, which in the case of the right ear, you're talking about the north-west region, if we're using a compass analogy. And that's also because that region of the eardrum's like the top part of the eardrum, the pars flaccida. It's a lot thinner, and that's because the middle layer of the eardrum, the fibrous layer, although there's fibrous tissue, it's not arranged and organised in the same way as the fibrous layer of the tissue in the rest of the eardrum, the pars tense, so it's more arranged, it's more densely packed, so it makes the rest of the eardrum a lot more tense, hence the name pars tensa. So this is the skin that we're peeling away, and when you get a retraction, you have to remember the skin starts to migrate from the center of the eardrum, where the hammer bone, also known as the malleus, connects to the eardrum. We call that region the umbo. That's the progenitor site of skin formation. So all the skin that lines the inner 2/3 of the ear canal all originates from the center of the eardrum, and then this skin slowly migrates radially across the eardrum towards the ear canal, and once it's on the ear canal, the skin then slowly migrates from the deepest region of the ear canal to the entrance. So we call that epithelial migration, and the epithelial is the outermost layer of skin, or epithelial skin cells, which form the epidermis, which is the outer layer of skin, the most superficial layer of skin. So when you've got retractions, some of the skin, it doesn't fully migrate, it gets trapped in the pockets. Now, you're always going to be concerned of an underlying cholesteatoma where a dead skin cyst can form in the retraction pocket, but the patient doesn't have it here, which is good, but it does prevent the full migration of skin. So it's like the eardrum's playing tug of war, it's not allowing the skin to fully migrate, and that's why it accumulates in the ear. So we just peeled a big segment there. Some of it did come out of the attic retraction. So there was some skin keratin accumulation in there. And now we're just peeling this fresher layer of skin. You can see it's still adhered to the canal wall, but this is not going to migrate. Eventually, this skin will become like the crusted skin that I removed right at the beginning of the video. So if possible, we're going to try and remove as much of this as possible. So I'm just going to peel backwards at the floor of the ear canal. And then we're going to slowly go to the posterior canal wall and just try to slowly peel that away. Going to go back deeper in the ear. So this is probably about 0.5 centimetre away from the eardrum. There is a bit of an erosion there just before the suction probe. There's a bit of a ditch there, which is not also going to help the skin migration, because when the skin has to travel up and down erosions and dents in the ear canal, it's going to slow it down, and you can get a formation of keratin accumulating there. It's not a canal cholesteatoma. There might have been one previously many years ago, but there's no ulceration. The underlying skin, it's still intact. You can't see the underlying bone. Possibly a bit of benign osteonecrosis where this part of the bone is not receiving adequate blood flow, so the underlying bone then dies and separates, and it creates a ditch, and then the skin sinks in to that erosion. So the skin is quite tough, but it is slowly coming away, as you can see. Now, we're not going to get every little last speck of skin. We can be here all day doing that. But as you see, I've got a fair amount out already. So again, just going to the back part of the ear canal. There's a hint of clarinetting there. I don't know if you saw the skin just vibrating a little bit, but it got sucked away very quickly, so it was no problem for the patient. There's a bit of skin there just in the anterior recess. So just got to be careful not to make contact with the bony part of the ear canal. So you can see that eardrum, about 9 o'clock on the eardrum, there's quite a deep retraction there. It's not a perforation now. There may have been a perforation previously, many years ago. And when you suffer from a tympanic perforation, so a hole in the eardrum, your eardrum consists of 3 membranes, 3 layers, and all 3 perforate. And when the eardrum re-heals, it's only the outermost layer and the innermost layer that re-heals. So that middle fibrous layer doesn't re-heal. So it makes that eardrum a lot thinner, and again, a lot more susceptible to getting retracted. And we call that a monomeric eardrum. So whenever you've got a healed perforation and you can see that thinning, we call that a monomeric eardrum. So it's just a bit of skin at the entrance. Again, I just want to peel this away just to make sure there's nothing lurking underneath, nothing sinister like a canal cholesteatoma. Quite often you remove a bit of damp skin like this off the floor of the ear canal and there is something underlying pathology. You wouldn't have thought so just by looking at this, but it happens quite frequently actually. So just across the skin, right near the entrance. Again, I'm just going to hover over. It's a bit difficult to vacuum, but it is coming away. And everything underneath is fine. So just a flake of skin there. If that comes away, brilliant. If not, it's not an issue. But I think it is going to come away. There we are. And then I think there's just a bit of across the skin right near the entrance. I've got quite a narrow entrance to the ear canal, quite a bendy ear as well. You can see on the right, where I am now, this is the patient's second bend, and the ear canal veers off quite sharply to the right beyond the second bend. So just going to be just going to look at the back part of the ear canal. So there is a bit of crusted skin here as well. So I'm just going to stretch the ear open with the endoscope. This region was a bit itchy for the patient, so when I was removing this, they found it a bit of a relief when I was peeling away the skin. So it's a bit of a blind spot. It's tucked in just behind the first bend. So if we didn't stretch the ear open with the endoscope, probably wouldn't have seen that. Again, just on the cartilaginous portion. When we work on this region of the ear canal, we can apply a bit of pressure to the canal wall because it's made up of cartilage and it's a thicker layer of skin. The skin is 1 millimeter in thickness. You have the epidermis layer, the most superficial layer. You have the dermis layer where the hair follicles are contained, and collagen and elastin, some of the blood vessels as well. And then you've got the inner layer, the hypodermis, or the subcutaneous layer, which is made up of fatty tissue. So there is a buffer there. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.